Thank you very much. Fantastic course. It's been great learning from experts here. I just changed the title a bit to "Do It" as well in there, and you'll understand why in a bit. I was a little worried taking on Jeff because he's like the golden boy of Ontario. I don't know if you know Jeff, but I read his patient testimonials. You know, Dr. Pulley's my hero. He cares about you as a person. He has dreamy eyes. He was my Superman, enough to make your heart melt. He has good hair. So I kind of felt like Steve Harper against Justin Trudeau, and this would be a problem. And you kind of see this billboard in Mississauga, and it's all over the place. They just put his picture all over the place, even if it's not even about cardiology. They're just everything. They just have his. But he has another side to him, which you may not know. Now, does anyone know what you call the people who follow the Grateful Dead? Okay. So, Jeff, please tell us, how many concerts have you gone to? And be honest. 62 concerts. Okay, so he's a deadhead. So that might be my only pause, for me to get in and win. And there's him partying with a bunch of his friends at a concert. And I don't know, they're into botany and things like that. So, and again. So let's get back to some TAVR or TAVI. So this was early on our experience, a 98-year-old woman. She was great. She was fantastic, severe AS. We went ahead and did this. And she did very well, and that's her exercising post-TAVI. She lived to almost 101. So at that time, we thought that was a win. And this is early in the day where we're trying proof of concept to show that TAVR was a good treatment, or at least a treatment that we could go on further. And again, she was very motivated. She had spunk and didn't mind taking a 98-year-old to the cath lab. And in fact, this patient was from Trillium, and Charles Kercher agreed to operate on her if we couldn't do TAVI, and our surgeon agreed to operate on her if we couldn't do TAVI, and that's the type of person she was. So, but we felt at that time TAVI was better, and she did well. And generally with TAVI, we look at things, and we see we're looking at the highest risk. And again, we're slowly changing. And it's quicker in some places, jurisdictions like Germany, where more TAVR is being done than SAVR. But generally, we look at a lot of things, technical issues, comorbidities, age, frailty. And we decide these are the patients that we should consider for TAVR, or if they're so bad, nothing, palliative care. And you look at not high risk for aortic valve replacement, young patients, bicuspid, no CAD, good LV, no prior CABG. Well, why not these patients? If we can do it in a 98-year-old, why not in a younger patient? What's holding us back? So, is the tide changing? Does anyone know where this is? No? No. This is actually Cape Cod. Yeah, Cape Cod, where I'm flying out to Boston today. So, when you look at surgical treatment of aortic stenosis in Ontario, you look at the average age. Again, they're younger than the average age of TAVR. And you look at people with good LV, and you look at isolated AVR, mortality rates are excellent, right? It's in the 2% range in Ontario. So, very low. So that's the gold standard, right? There it is, 1.9% for good LV function. But is it really the gold standard? Intermediate risk, recently partnered to TAVI. I'm not going to get into all the data, but you can see that TAVR does as well as surgery on many fronts. But patients don't have a sternotomy at the end, and patients generally go home, right? What percentage of the patients that are undergoing TAVR today go home the next day? I would say at least 50% now. Even frail 85-year-olds, they're going home the next day, especially with the wake procedure that we're doing for the percutaneous. And when you look at the partner studies as they've progressed over time, and you look at SAPIEN 3 transfemoral, and now that was not a randomized trial, but they used that data and they compared it to actually trials in 1.1%. I mean, at 30 days, 1.1%. That's probably equivalent to angioplasty all comers. Again, everyone thinks angioplasty 1 in 1,000 risk of dying. It's not 1 in 1,000 when you take all comers. So at 1%, I mean, that makes the 2% look awful. Notion study, a very, very small study done in Nordic countries, showing again that transcatheter approach with the Corevalve does as well as surgery. Now, it's not statistically significant here, but does very well. So, the gold standard, tissue aortic valve in young patients. Well, when you actually look over the time, it's not a perfect therapy, right? We are replacing one disease with another disease. At 10 years, about 20% are not around. And these are young patients that probably should be around. And when you compare them to age matched without this disease, they fall below that. So mechanical valves, young patients who have mechanical valves, they don't do that much better, right? They are anticoagulated. They have complications, the anticoagulation. So again, the therapy that we have in terms of the gold standard is not a perfect therapy. So I would say that transcatheter should be really considered. And partner 3 is being done, but do we have to wait for those results? In Canada, we were doing TAVR before a partner came out. We thought was the right thing to do, as John Webb would say, jumping out of an airplane doesn't need an RCT. It's a good idea to have a parachute. So partner 3, and sorry about my phone going off, you can just turn it off there. So we'll wait these results, but I think we can start getting on with this. We don't have to wait for the lowest risk patients, but lower risk patients I don't see a problem with. So,
come on, do it. Do it. Huh? Come on, do it. Do it. Do it.
So,
Okay.
Do it. Do it. Do it. Do it. Come on, do it. Seriously, do it.
so this is from Starsky and Hutch, and clearly Ben Stiller
it.
says to do it. And then here's Jeff coming in afterwards, finally agreeing.
Do it. Do it. Do it.
Okay, so I think that's the end of it there. And again, I wouldn't be saying TAVI is a team approach, and everyone has teams doing all these, whether any type of structural, any type of congenital, and we have to remember that these are the people who allow us to get to treat these patients safely. Thank you.